So our next topic is thinking about how do we coordinate care in these increasingly complex interprofessional teams I've been telling you about. So we know, if you think back to that long list of professions, years ago you might have gone to the doctor's office and you might have had a doctor at that doctor's office and a nurse at that doctor's office and some sort of staff administrator in that office. Now you go to the doctor's office and there are many doctors and many staff, and those staff all play different roles. And the upside of that is that you have more people to call when you're sick. The downside of that is you have more people to call when you're sick. And trying to get those folks to talk to each other, to help coordinate care, it may be a real challenge if you have to go from one doctor to the next, or you have to go have physical therapy and you're wondering if your doctor knows that things aren't going so well at physical therapy, or if you're a patient who gets a lot of their care at home because you're frail and elderly. Does anybody know what's going on in your house, other than every 3 months when you go to the doctor? So we have to think about whether better care coordination can address the fragmentation that we see in healthcare. Add to that what we've just been talking about with role conflicts between professionals, and the patient may really be in a position of trying to balance a lot of competing interests, and the patient may be relied upon to deal with a lot of the inefficiencies in this system. So this is a big problem, and a lot of people are thinking about it. And we're going to hear about some proposed solutions to these care coordination issues. So what are some ways that we see failures of care coordination? We see them in increasing hospital readmission rates. We know that there's a number of people, especially folks who live alone, people with multiple chronic illnesses, who really come back to the hospital a lot, and who might go home and bounce back because they don't manage their medication change very well, or they don't get the home care support they need, or their primary care doctor doesn't know they've been in the hospital and come home. So we're tracking hospital readmissions. We also are thinking about tracking missed appointments. Are people scheduled and don't come for key screening appointments or key follow-up appointments? And we've known for a long time that people who don't have a lot of money, or people who don't have insurance, or people who have not so good insurance, miss appointments based on their ability to pay. And that's where we see big gaps between people in terms of their effective follow-up for chronic illnesses or cancer or key screening. We also see these challenges in referral barriers. You go to see the cardiologist says, "What are you doing here?" You say, "Did my records get here, Dr. Smith?" And Dr. Smith says, "No, I didn't know you were coming today and I don't have your records, so maybe we need to see you again." So you get these inefficiencies that come about because the records didn't get there or the information isn't exchanged. And sometimes that leads to duplication of tests. Well, we don't have a recent EKG, we'll run another one. We don't have a recent CT scan, we'll do another CT scan. So we have to think about how these coordination challenges really are impacting inefficiencies in our system and perhaps duplication. You go to one doctor and they change your medication, you go to another doctor and you get the same issue, right? Those two aren't talking to each other. So how do we deal with these complexities? The Agency for Healthcare Research and Quality talks about several elements of care coordination, and they want to think about how these patient care activities can be better organized. And they want to recognize that coordination is not just about doctor to doctor or doctor to hospital, it's about patients and those people. And how can you bring the patient into that circle so that everybody's sharing the same information. And then their definition talks about somebody or some entity being the organizing force. And typically in our health system, we're hoping that happens in the primary care setting. They want to talk about care coordination over time, even within the healthcare team. You know, if you have a doctor and a nurse practitioner, are those people coordinating care? If you go have a test at your local hospital, is that information getting back to your doctor? And then finally, we're thinking across teams, across systems, and how we can share information. If you have a college student who has a condition here in Massachusetts and they go to college in Pennsylvania, is that information going to move back and forth with your college student, or is it going to move back and forth between the providers? We see this issue a lot with snowbirds to Florida in the winter. How does their information come back and forth? The map that you see is a fairly a large map developed by the Agency for Healthcare Research and Quality that just tries to put all of these little pieces into one big circle and say, here's all the little nodes, that have to be coordinated, and really puts patient needs and preferences at the center, tries to say, we need those patient family perspectives along with the primary care perspective. But this is, there's a lot of pretty colors here, but this is a very difficult set of services to coordinate, as you might imagine. So how are we thinking about doing this? And there's a couple of policy initiatives. One is the Center for Medicare Services is really pushing a concept of accountable care organizations. So it's trying to get that whole continuum of care brought together to manage care for chronically ill populations that tend to be those people who use a lot of services, and try to avoid that unnecessary duplication. To the degree that those health systems are able to do this, then they will share in the Medicare savings that are achieved by this more efficient care. And we're right in the heart of these demonstrations, starting to look at the first data from the ACOs that were the pioneers or the earliest versions of this. We also have seen from NCQA, the National Committee on Quality Assurance, the concept of a patient-centered medical home. It's another organizing concept that really is trying to talk about primary care as being the home to which you always, that you leave from and you come back to when you travel around the healthcare system. So you hear two themes here. One way that we're doing this care coordination, you have all those little nodes, and how are those people all going to work together? One concept that has really been pushed a lot over the last couple of decades are patient navigators or coaches or community health workers who become sort of the glue that helps you get from point A to point B, who helps you understand why it's important to get your screenings and to get followed up if you have an abnormal test. We've seen this a lot in cancer care to get people from diagnosis to treatment and through complex treatment. We've also seen this in complex conditions like diabetes. So you have people on the ground and sometimes out in your community who are helping. The other huge investment has been in electronic health records, with an idea that if people don't actually talk to each other as humans, they might talk to each other using computers. And we'll see. But we've had, with the Obama administration and continuing in the Affordable Care Act, really a very large push to equip hospitals and physician offices with electronic health records and to use them in a meaningful way. And I would say what we know from some studies I've done with my colleague Kate DeRoche and some important work with the Office of the National Coordinator on Health IT, that we're starting to move along that adoption curve and uses, the meaningful use is starting to happen, but there are a lot of challenges with that. So my colleagues Peter Bierhaus and David Auerbach looked at a couple of these different models, thinking back to that workforce supply set of issues as well. If we coordinate care better, does it impact our supply and demand for health professionals? And they looked at nurse-managed health centers, which I told you about in those independent practice models, and these patient-centered medical homes, which have a higher proportion of nurse practitioner and physician assistants in them. And basically what they found is that all our projections and models of shortages are very sensitive to changes in these primary care delivery models. And right now, our standard projections that I've shown you of how many doctors we think we're going to need and how many nurses we think we're going to need, those don't really reflect these new care coordination models. And so what they are saying is that if these models continued, and grew, we could probably ameliorate some of these projected imbalances, and we might even be able to eliminate that physician shortage because we've got these other folks who are doing some of the work of physicians, and we're training more of these nurse practitioners and physician assistants. A lot of the key to this is how many patients can they see, how many hours can they work, and we have to get to the point where we understand a lot of those details of the employment before we understand whether this is the solution that everybody hopes. So that's a summary of a number of the issues in care coordination in fragmented teams. Next up, we're going to be talking about professionalism and professional codes and how people might work together more effectively.